Thank you. Good morning, everybody. Happy to be here with you all this morning. In the next minutes, I will provide you an overall physiological overview on the technique of measurement of worker breathing and what are the clinical implications of this. No, this is some research grants that we have or have had in the department. And from a physical point of view, very rapidly, you need to know that that work is a physical term that implies a movement or a change in volume across a gradient of pressure. And in respiratory physiology, the units of measurement are usually expressed in joules. And to give you an idea of magnitude, a joule of work means to move a liter of volume across a gradient of 10 centimeters water of pressure. In other words, is a parallelogram with a base of pressure of 10 centimeters and a height of volume 1 liter, and the area inside this parallelogram is 1 joule. Yesterday you heard about not the mechanical arrangement of the lungs and the chest wall, and both are the mainly components of the respiratory system, and these structures, all of them have a relevant pressure. And the relevant pressure for the whole respiratory system is the airway pressure, which is shown here. And when you have a patient connected to a ventilator and you measure the airway pressure and you measure the change in volume and you build a loop of pressure and volume, you calculate the work which the ventilator is doing on the whole respiratory system. And here, this is one example of this. You see a passively ventilated patient, and here you can see the airway pressure trajectory over time, and here you see the tidal volume. And when you simultaneously plot the change in pressure over tidal volume from the very beginning of the inspiration up there to the very end of the inspiration, this whole area is the work needed to inflate the system during this particular breath. In this example, we had a tracheal catheter inside. So again, this line represents the beginning and the end of airflow measured at the tip of this catheter in the carina. And this surface here to the right, this means the resistive pressure drop across this particular endotracheal tube, which, as you can see here, is a significant amount of work. When the patients are assisting the machine, as you can see here, there are inspiratory spontaneous efforts. You see here some scalloping in the airway pressure trajectory. The measurement of work is more complex, and the only way that you have to solve this is to superimpose both airway pressure tracings over time during the controlled breath up here, and during the assisted breath down here, and this dotted surface represents the amount of work that the patient is doing to assist this particular breath. This is the work that the patients dissipate during two different conditions, to the left during spontaneous breathing and to the right during assist-control ventilation. This is data by John Marini, and you can see here that there are patients that even under assist-control ventilations, they exhibit an amount of work which is similar or very close to the work that they had during spontaneous and assisted breathing. And here, in this light blue boundary, you see the amount of normal work in physiological terms, which is between 0.2 and 0.7 joules per liter of ventilation. Another way of calculate work is using transpulmonary pressure volume loops. No, the issues about transpulmonary pressure were dealt with yesterday in detail by Dr. Pesenti. I'm not going to comment further on this. And I will focus in this kind of measurement which indicates you very precisely the amount of energy that the respiratory muscles are using for the worker breathing. And this is done via the esophageal pressure volume loops. No, the esophageal pressure is a surrogate of pleural pressure in this case. And by using loops of esophageal pressure versus volume, appropriately plotted in the so-called Campbell diagram, I will explain you later on this, you can know what's the amount of energy that the patient is doing for breathing, being or not connected to a mechanical ventilator. This is the so-called breathing Campbell diagram. This is a complex figure which essentially takes into account several concepts. First of all, it takes into account the pressure-volume relationship of the chest wall, which is this continuous black line here to the left, which represents the relaxation pressure of the system. Muscle pressure equals 0. And to the left, you see how this pressure departs from the relaxation. So it's the real muscle contraction, taking into account the amount of auto-PEEP, if any, and the respective partitioning in the all components of work. The resistive part by joining the points of zero flow at the very beginning and the very end of inspiration. Here is the resistive work. And the elastic, non-intrinsic PEEP related worker breathing. And here with this purple area, you see the amount of work related to the amount of intrinsic PEEP, which as you can see is again a parallelogram with base intrinsic PEEP and height tidal volume. To do this, you need to have esophageal pressure signals, and for proper measurements you need also to have gastric pressure signals. Why? Because in some instances there is a recruitment of expiratory muscles, which you can see here, and these muscles suddenly relax at the beginning of the inspiration, and this relaxation or this sudden drop of the expiratory muscles pressure needs to be into account to correct for the intrinsic PEEP, which you see here. This is in yellow, the esophageal pressure tracings, just in the very beginning of the inspiration. Here at the P2 point, there is the esophageal pressure at the point of zero flow, so this difference means the auto-PEEP. And when you plot this signal in a Campbell diagram, here you can see the esophageal pressure at the beginning of inspiratory flow. This distance here means the pressure needed to compensate for the auto-PEEP, a couple of centimeters of water, and this is how the inspiratory progresses until the end of inspiration. And again, here in this cycle, you see that the amount of work needed to overcome the intrinsic PEEP is about the 20-25% of the total work of breathing per this breath. Of course, the measurement of worker breathing implies that there is a change in volume within the respiratory system. But this is not always the case in all the patients and for all the breaths. Say it differently, there are some breaths in which there is no volume change, for instance, because there are wasted efforts, and you need an alternative to estimate the amount of energy used by the respiratory muscles. And this is This is done via the pressure time indexes, and here you see, well, the pressure time index of the respiratory muscles, which again requires the insertion of balloons into the esophagus and the gastric cavity. And here you can see in this esophageal pressure tracing from the very beginning of the inspiration until the end of the cycle, how you can partition the amount of effort in terms of intrinsic PEEP, which is this drop in pressure without changing volume. This is the relaxation line of the chest wall. So all this area here is the work or the amount of pressure used to overcome auto-PEEP. This small triangle here is the amount of energy needed to open the valve of the machine, and then the amount of work needed during the whole inspiration, again, a partition in elastic and resistive components. All these techniques of measurement have been used to analyze the physiological effects of ventilatory modes or different working principles of the same ventilatory mode. And here you can see how, for instance, as long as you increase the levels of pressure support, there are parallel decreases in both the power of the breathing, the transdiaphragmatic pressure, and the oxygen consumption of the respiratory muscles. And down there you see that, generally speaking, the amount of work expressed here as power of breathing is nicely correlated with the oxygen consumption of the respiratory muscles. Again, here in this study by Tobin's group, you can see what are the effects of different ventilatory modes, SAMB, pressure support, and a mixture of two across different levels of support, from no support to the left to 100% of support to the right. And again, as long as you decrease support, there is an increase in the inspiratory muscle effort. And again, what you can see here in this in this lower part of the slide is the amount of work that is dissipated during the inefficient inspiratory efforts. And again, you can see that there is a sort of balance, being the highest amount of work dissipated in wasted inspiratory efforts when the support is highest, whereas the total amount of work is lowest, as well as the sensation of dyspnea is minimal, whereas when you decrease the support, there is a progressive increase in work, but there is also a decrease in the amount of wasted efforts. Also, this technique has been used to understand the mechanisms underlying the weaning failure. And again, what you can see here is that patients who fail a weaning trial, they mainly do so because they increase their effort to breathe, and this is due to the increase in the elastic component due to the auto-PEEP, and also due to the significant increase in the resistive work of breathing during these failed weaning trials. Also, this is important data indicating how important are the flow settings in the ventilator. And here you can see in this study the settings of volume assist control ventilation with a tidal volume of 8 mL per kilogram with a relatively long inspiratory time, so a relatively low inspiratory flow. This is the same with pressure control ventilation, same inspiratory time and same tidal volume. So the peak air flow is highest during pressure control in comparison with volume control ventilation, and thus the amount of work or effort is much lower. However, when you decrease the inspiratory time, keeping constant the same inspiratory flow, so you increased the inspiratory flow here during assist control ventilation, you can see that there are no differences between volume control and pressure control in terms of inspiratory muscle effort. Again, this is another example showing how a completely non-invasive measurement, the airway occlusion pressure, is well correlated with the changes in worker breathing. Also, the absolute values of airway occlusion pressure and worker breathing are well correlated. And here you can see more recent work in which, using this technique, we compared during the weaning period different methods of spontaneous breathing trials, low levels of pressure support with a small PEEP, 5 centimeters of water, low levels of pressure support without PEEP, and the classical TPS trials. And again, here you can see that the physiological effects of these different breathing trials are totally different in terms of work of breathing, as you can see easily here in this huge esophageal pressure swings. And in terms of work, you can see that the amount of work during both methods of pressure support with or without PEEP, the amount of work was much lower in comparison with the TPs, and it was the same when you measured the indexes of the pressure time products. So just to finish and to summarize, the technique of measurement of work of breathing is interesting to evaluate the physiologic effects of different ventilatory modes and even to evaluate the different working principles of the same ventilatory mode. To analyze the effects of therapeutic interventions, for instance, if you give bronchodilators to your patients, and of course to understand mechanisms of disease such as the mechanisms underlying weaning failure, etc. Thank you very much.